So welcome everyone to this webinar this morning that talks lots about this great project that the Center of Excellence has had the privilege to lead over the last couple of years. This morning, Lindsay and I are going to present on behalf of the Center about this project and the documents on brief intervention that arise from it, but I really want to acknowledge the rest of the project team. Tasman Nathu is the one who's created, created the knowledge exchange products from all the various sources of information that we gathered over the course of the work. And Rose and Natalie did the evidence reviews with us. Lorraine really helped with the conceptual thinking and bringing the tobacco work in, as well as all the other substances. And Karen Gelb joined our team on behalf of the University of British Columbia School of Midwifery and really brought lots of wisdom from the practice and knowledge exchange work happening in midwifery. And the Canadian Centre on Substance Use and Addiction also really joined and walked with us throughout the project, and we really appreciate their support. But most importantly, we need to acknowledge the financial assistance for this Dialogue to Action project, which was received from the Public Health Agency of Canada. And of course, acknowledge that, the views represented in the webinar are not necessarily those of the Public Health Agency. So our goals today are to summarize some key findings from this project about brief intervention on substance use with women, including what we learned in a lot of consultations across the country with providers as well as from the literature, to share some promising approaches to brief intervention and support, and to involve you in some critical thinking about how we can improve our capacity to discuss substance use with girls, women, and their support networks, and to introduce a couple of resources to support practice that we've generated from the project, including this one that's called Doorways to Conversation. Sorry, I'm just having some trouble changing my slides here. There we go. So the agenda is here. Please, as you saw in the opening slides, type in your questions to the Q&A box in the lower right-hand corner of the screen. And if you want to download the Doorways to Conversation document as we go along, please do. It's available from our website, which is just here. And under the featured projects, you can see that there's lots of information we've gathered over the course of the project, including these two new documents we're going to talk about today. So the overall project goal was to inspire and facilitate health and social care providers to incorporate brief intervention on alcohol and other substance use in their daily practice with girls, women, and their partners throughout the perinatal period. And, we came at this project from this theory of change, that bringing people together across sectors and disciplines, working in a participatory, appreciative, and dialogic way can really support the uptake of practices such as brief intervention. And, we've been doing this for a number of years, actually since about 2004, that's kind of bringing communities together to talk through practice and policy change. And, we're very much involved in leading a national network of service providers, birth mothers, policy analysts and researchers working on the prevention of fetal alcohol spectrum disorder. And in the course of that work, we've really talked about multiple levels of work that is needed to prevent FASD. But this morning and in this project, we really focused in on the level 2 work, the how do we do a discussion of alcohol and related risks with all women of childbearing years and their support networks. So, you know, when we went in to look at some of the prevalence about alcohol and other substances in pregnancy, you know, we found lots of gaps as well as strengths in the statistics. If we just look at the alcohol one, you can see that some of the latest statistics are showing us that girls and women over 15 years of age who use alcohol at risky levels monthly or more are about 18.5%. And some recent analysis by our colleague Gerald Thomas from the Ministry of Health in BC really shows that this risky drinking is continuing to increase. So lots of reason for us to get serious about how we discuss these substances with girls and women. And, you know, if you look at the last point under opiates as well, you can see really that the rate of infants requiring support for withdrawal at birth has really increased over the past decade. So, you know, we really think there's lots of opportunity now for us to improve our practice around how we talk about alcohol, tobacco, cannabis, and prescription opioids with women in really helpful ways. And as we're doing that, of course, there's lots more textured and contextual information that we need to be thinking about beyond the statistics about what are the influences on women's substance use. And, you know, some of those can be very positive things like having good social support and nutrition and resilience, and others are really challenging things like racism and grief and loss and the ways in which mothering policies can really prevent women from feeling safe to access prenatal care. So lots for us to think about, and as we were doing this work, it really reminded us that many of the themes that we've been talking about over the last few years are really important for us to lead into this work, that we would be women-centered, harm reduction-oriented, that we would practice cultural safety and humility in this work, and be trauma-informed. So we're going to talk this morning lots about how we're going to bring this in based on your thinking and the work from the evidence. So I'm going to turn it over to Lindsay to talk a bit more about the project.
Thank you, Nancy. So this project had 3 main objectives. We had an environmental scan of existing brief intervention tools and approaches, and that was done through 13 regional consultations in every province and territory, excluding Quebec. We had 2 in Ontario, 1 in Toronto, and 1 in Thunder Bay. Our second objective was a review of existing literature on brief intervention through what we were able to see in academic and gray literature. And the final objective was promoting best practice, and this had a number of activities, including webinars that we held with the Association of Ontario Midwives, and one held in partnership with the Ontario Association of Interval and Transition Houses, which had a panel of anti-violence workers from across the country. We also met with key stakeholders to have 2 virtual working groups on child welfare and perinatal data collection, all of which I will go into in a bit more detail. So the environmental scan, as I said, was done through a series of 13 regional consultations, and we specifically sought to invite these 8 professional groups, and some sessions did include others, including researchers, those who work in education, justice, policy, and other relevant professions that are either in a position to integrate brief intervention into practice or into policy. And these scans were really pivotal to the project because they really framed what brief intervention and support look like nationally and what opportunities there are to integrate brief intervention into practice and what resources can help support that integration a little bit further. These are a few of the resources that we shared in the regional sessions. So the first two resources that you see, Women in Alcohol and Women in Prescription Pain Medication, were done by the Center of Excellence and can be found on our website. The last resource is one that was done by Best Start Resource Center on the risks of cannabis use in fertility, pregnancy, breastfeeding, and parenting. In each of these sessions, we also talked about 4 specific questions that we asked providers to identify what their practice is in discussing substance use with women, what is working well, what resources can help support their work, and what uptake could look like now that we've had those consultations. And it was really important to us to come from a strengths-based perspective because there is a lot of really great and existing work being done, and we wanted to highlight that in each of the sessions. We also acknowledged and felt it was important to see what was available in the literature. These are 4 fact sheets that we have on the health effects of alcohol, tobacco, cannabis, and prescription opioids. And we updated these before the regional sessions, but in our literature search, we felt it was really important to see what evidence was available to support the uptake of brief intervention and support and what that practice looks like largely in Canada and the States, but also in Western and Northern Europe, Australia, and New Zealand. And lastly, we had 2 virtual working groups. And these 2 working groups were identified because of their relationship to women in substance use. And so we held one on child protection and one on perinatal data collection. And these were identified before the project started, but in many of the regional sessions and in literature, we could see that there were opportunities to better connect child welfare and substance use. And dually, there was a need to better align perinatal data collection with brief intervention because there's so much literature that does demonstrate the efficacy of brief intervention for reducing harmful or risky alcohol use, but that data collection and asking women about their substance use needs to be done in an educative and empowering way. So we have provided an overview of what the project is, but it's also really important to highlight what brief interventions are. And so brief interventions are collaborative conversations between an individual and a health or social service provider about issues including substance use, mental wellness, contraception, and experiences of violence or trauma. They can include other health examples as we'll highlight in a couple of later slides. Brief interventions can be informal, structured, or semi-structured, and they can range from a 5-minute conversation on what a woman knows about their substance use to a 15 to 30-minute counseling session. And these conversations can be held one time or over a period of time. And because these are collaborative conversations, they can be really versatile to address what a woman and her support networks need. And so oftentimes it's framed within the realm of what physicians and those in primary care can do, but there are opportunities for everyone who's working or many who are working in health and social service to be engaging in brief interventions and altering them to adapt what fits for the woman and her support network. Oftentimes, when we're talking about brief interventions, we frame it within screening, brief intervention, and referral or referral to treatment. And this is what the clinical guidelines often suggest. And when it's done this way, it looks as though screening should be done first, and then only after someone has screened positive for risky and hazardous substance use should providers engage in brief intervention. But in our understanding and also what we heard from the regional consultations, we really wanted to broaden this approach to recommend that brief interventions can not only be done to identify problematic substance use, but also as an opportunity for education, relationship building, and an ongoing dialogue about the role and impact of substance use or other behaviors in women's lives or their support networks' lives. And this approach was something that was welcomed by many of the providers who felt as though screening did not fit into their professional approach. They also expressed that screening could focus on a woman's behavior in a way that was seen as judgmental or stigmatizing or led to an unequal power dynamic. And this was especially prominent by providers that work with subgroups of women, including Indigenous women and girls, who have disproportionately been screened for substance use. Providers also mentioned that screening can create an unequal power dynamic that was really fostered by asking yes or no questions that didn't open up the doors for conversation. And so by taking this alternate approach where brief interventions are a little bit more opened up and we don't necessarily do screening first, providers felt encouraged and valued brief interventions as an opportunity to foster these relationships and act as doorways to conversation. In the evidence and also across these sessions, we noted that there are several barriers to brief intervention, which may include time constraints, lack of training, and the fear that conversations about substance use may negatively impact relationships with patients or clients. Most commonly in the regional sessions, we heard that providers were really interested in engaging in brief interventions, but they didn't necessarily feel confident enough to have these conversations. And this was particularly common where providers didn't feel that they could make referral in cases of risky substance use or where women needed to be connected to other services, but also how to continue these conversations when something didn't go right in them and really make women feel comfortable. And so to address these barriers, we really saw that education and training was the most effective in addressing it. And so education can be on how to engage, strategies to engage in brief interventions, integrating it into medical or nursing schools or other education as relevant, and it increased knowledge and use of screening and brief intervention because people saw the impact that it can have and the efficacy on reducing substance use, but it also increased the confidence in providing health education and having these nuanced conversations about substance use. However, we also saw that it was really important to be open about what the intention behind brief interventions are. And so for providers that were a little bit more apprehensive because of how it may impact their relationship with clients, it's really important to note that why you're having brief interventions and articulating the role of consent, confidentiality, and privacy within brief interventions, they are able to have a conversation that is a little bit more open and really framed from a non-judgmental approach. And ways and strategies of engaging in brief intervention is the second resource that Nancy alluded to before on 50 Ideas for Dialogue, Skill Building, and Empowerment, and that is also available on our website. In addition to education, there's also evidence, and we heard about the roles of web-based and mobile resources in screening and brief intervention, and these can be both influential to providers, but also women. So, for example, virtual screening or brief intervention can help overcome some of the issues with limited service provider time or capacity to engage in these conversations. And web-based tools such as this one from the Saskatchewan Prevention Institute highlight motivational interviewing strategies for talking to women about their substance use. Online approaches can also be effective in reaching women in rural or remote communities, help deliver health messaging, and can increase anonymity. And this is really important for women who want to address their substance use and want to understand their substance use a little bit better, but expect or perceive stigma or judgment and it can also help identify a higher proportion of women who are using substances in a risky way and could benefit from further health interventions. So Nancy, I will pass it back over to you.
That's great. Thanks, Lindsay. So, you know, we haven't put references on all these slides, but, you know, the vast material that Lindsay just covered comes from the literature as well as the conversations we had with people across Canada. And in the Doorways document, I believe there's like 170 references if people are interested in going directly to the literature. But I'm going to turn now to talk a little bit more about the purpose and the practice of brief interventions that has really evolved in our thinking over the time of this project. And, you know, in essence, you know, it really has caused us to think about brief interventions, as Lindsay mentioned, not only in the context of screening and referral, but more broadly as conversations that invite curiosity and examination of interconnected health issues. And it's not something that's seen as, you know, case finding for problematic use only, but it's really lots about helping people think through their relationship to substances and particularly some of the wider influences on their substance use and some of the things we know about the connections between various health issues and substance use. So, you know, we've come to see this idea of brief conversations as really supporting people in learning about health issues affecting them, and to reflect on what health promotion strategies they are employing currently, and is there a need to enhance those in any way. And to really help people make any needed change in both their health overall and their substance use and or other determinants of health other than strictly health-related ones. And support people in making these connections between, you know, things like sexual health and mental wellness and other determinants of health that could really support their plans for change. And helping people identify and strategize how to address some of these underlying concerns that may be directly or indirectly affecting their substance use, like gender-based violence or lack of resources, etc. So you can see that, you know, this is a pretty wide territory that involves people, a range of service providers in. And what we saw as we went across the country, that people were engaging in brief support in lots of different ways across these 8 professions that we invited to the meetings. And there's a great table in the document on pages 14 and 15 that really summarize some of the opportunities that people saw for doing this kind of work as it related to their domain of practice. And, you know, I just mentioned the midwifery one because there was so much in the literature about the role of midwives and such interest as we went across Canada, but really that midwifery model of care is really well suited for open conversations about substance use and brief interventions, because it is based on a holistic approach to care, and it's rooted in trust and relationship building and really grounded in caring for women where they're at. So this really creates lots of space for women to have these, you know, conversations with midwives as providers. And, you know, it's really inspiring, I think, some of the ways in which midwives spoke about their work and in the context of the work with the other providers as well. And, you know, I think the one thing that Midwives mentioned in terms of the stretch for them in some ways is wishing they had a broader scope of practice to really have more opportunity to be doing this work in the pre-conception period as well. And many of the other providers, as you can see here, were much more likely to be already thinking about preconception interventions as well. So, you know, way too interesting and complex to go into this morning, but really encourage you to have a look at the thinking of all these different professions about their relationship to this work. So I'm going to talk a little bit more specifically about these practice approaches. And again, you know, this I think is a really great table within the document that very much helps you look at some of these practices that where all people are already doing and the links amongst them. And I guess for me, that was such an interesting piece of the work, was to be able to see the tremendous work people are already doing to be women-centered or strength-based or harm reduction-oriented or trauma-informed. And this table really summarizes well, I think, what these approaches have in common. Things like collaboration and things like, you know, supporting choice, etc. So it seems so evident to me that when this is coming from so many traditions that people in various domains are already employing, that it really speaks to me that this is the direction we need to be going in. The final column in this table really talks about how these particular practice approaches really are connected and are relevant to brief intervention and support. And it's a rich bit of thinking, I think, to be able to see these approaches lined up with each other and tied in directly to their relevance to this practice. So again, hopefully something that you will find really helpful in the course of your work. Now, you know, we've talked a lot about brief intervention support and how it will vary according to the role of the service provider. And I think that's the thing that really struck us as we talked to people, that it can be, you know, wherever you are located, you can really pick up aspects of brief intervention that connect most closely to your domain. And in the document, there's a wonderful set of checklists that really help you, and the picture of the alcohol checklist is right there, that really help providers think through, you know, what of all of the possible ways in which we can discuss alcohol with women most closely aligns with your practice. So for, you know, the prenatal providers, perhaps, you know, the way in is through nutrition and some of the things that the Canada Prenatal Nutrition Programs are strongest on. For the sexual health workers, really lots of possibility to talk about fetal alcohol spectrum disorder prevention in the context of conversations about contraception. For physicians, it may well be much more about talking about heart health and cancers and other things that are direct risks of risky alcohol use. So I think there's quite a lot of possibility for us to expand the work and find our place within it. And in the document, we do this for all 4 of the substances we've been talking about: alcohol, cannabis, tobacco, and prescription opioids. And so hopefully that'll be quite a good sort of encouragement for people to see their place in doing this work. And at the same time, recognizing that you don't have to do it all. And this doesn't have to be lengthy or intensive. It can be really, you know, incorporated well within what you're already doing, and can be tremendously helpful in the course of just having a conversation about your regular work, inviting reflection on substance use. In that way, it becomes much less of a stigmatizing thing or a thing that women are afraid to discuss. And much more of something that, you know, is really just helpful in terms of increasing all of our knowledge about how these substances affect our health and how they're connected to each other as well. So another, I think, really important way to go. So this, in some ways, becomes the essence of these documents, I think, is really inviting reflection on these kinds of questions. What substance use topics can I routinely address in my day-to-day practice? How does addressing substance use fit with my model of care or program philosophy? How does my particular role or relationship with girls and women influence the topics I'm best situated to discuss? Is it possible to discuss more than one substance or health concerns in my conversations at a time? And I think this is one of the things I feel most strongly about, is that, you know, if we isolate conversations to be only about tobacco or only about alcohol, we miss tremendous opportunities, both to help women understand that, you know, the risks of multiple use, but also to be able to show us where they are making changes and to be able to build on successes with other substances and apply it to ones that still may be of concern. And finally, you know, are there topics that we could better address if we had organizational support and really engaging our organizations in how we can create the space for us to be upping our game on this, you know, really important public health area, and recognizing that it's not only the individual provider and woman that it's the whole systemic way that we work that needs some thought, and we'll come back to that in a bit, and I'll just let you pick it up a bit here, Lindsay, on some of the examples in the document.
So I'm actually not going to talk too much about these slides because I would like to invite some time for a rich and lengthy question and answer period at the end. But in these slides, we have highlighted different practice approaches and breakdowns by particular professions or professional areas, and also by subpopulations. And these are also highlighted in the Doorways to Conversation report and the 50 brief intervention ideas. And so for the purpose of this webinar, just to provide some examples, we're going to focus on 3 professional areas and 2 subpopulations. And so I'm going to start with primary care providers. And in the literature, we really see that brief interventions are focused around primary care providers, oftentimes physicians, and there's a tremendous variation in the willingness, comfortability, and confidence in talking to women about substance use. But there are also great opportunities for all those who work in the primary care setting. And brief interventions in primary care settings have been shown to reduce alcohol, tobacco, and other substance use-related harms, and have also been really important in acknowledging that substance use can be an integral part of an individual's health and overall well-being. So by integrating brief interventions on substance use into a primary care setting, there is the capacity to address a range of potential harms and promote overall health. And so on this slide, what we have highlighted are a few opportunities for how brief intervention and support can be integrated into primary care. And this example on alcohol, tobacco, and breast cancer really emphasizes what Nancy was mentioning on how brief intervention can be integrated into regular practice. And so in having conversations about breast cancer, as women are articulating their concerns or how to reduce their risk of breast cancer, providers do have the capacity to talk about the impacts of alcohol and tobacco use on breast cancer and opportunities to reduce or quit use of these two substances. There have also been really great examples in sexual health settings. And so one great example of a brief intervention that focuses on multiple areas is, as again Nancy mentioned earlier, is Project Choices. And this is a brief intervention that focuses on both substance use and contraception, and particularly looking at reducing alcohol-exposed pregnancies by helping women reduce or stop drinking, use contraception effectively, or both. And there are many other opportunities for brief intervention by sexual health providers, and that includes what's highlighted on these slides. So including information about substance use or local services, local substance use services, information about substance use and reproductive health, and supporting reflection and healthy decision-making related to substance use. And so this, working in a sexual health setting, there are great opportunities to talk about substance use generally, but also go beyond the range of talking about brief intervention only being used for substance use and really integrating focuses on contraception, on violence, on trauma into practice. And lastly, we've highlighted brief intervention in anti-violence settings. And anti-violence workers are uniquely positioned because historically, many anti-violence services prevented women who reported substance use from accessing their services. And this has very much changed as organizations and agencies have shifted towards harm reduction. But given its legacy, it's really important for anti-violence providers to be clear about their agency's policy towards substance use and explain the role of having these conversations. That way women are able to build trust in relationships with their worker. And this might require having ongoing conversations rather than a one-time brief intervention to really facilitate relationship development. But brief interventions in anti-violence settings look very unique and very special because they can not only support women in developing alternate coping strategies, but they can be really effective in developing and co-creating safety plans for women, and also determining which services and supports may be useful to them. And that is critical because of the links between substance use and experiences of violence, and oftentimes how many women who are experiencing violence or are using substance use often need to address other determinants of health before they are able to effectively address substance use or leave violent situations. And so we also focused on two subpopulations, as I mentioned. And so the first is young women and girls. And increasingly what we heard across the country is how important it is to create preventive policies and programs that are different for young girls than they are for women. And so rather than, I think for girls and young women, often that looks like an abstinence-based approach. But in engaging in brief interventions, providers can focus on harm reduction, skill building, and identifying individual strengths. And so brief interventions can be used to help girls identify their own values about substance use, identify what their relationship to substance use is, what they think about other people who use substances, and when they themselves are using substances. And these resources are some that are from the Girls Action Foundation and the Saskatchewan Prevention Institute. And these are resources that were specifically created for girls. And I know that there are many others across the country, but these are just a couple that we highlighted. And lastly, we wanted to highlight the role of brief intervention and support with Indigenous women and girls. For Indigenous peoples and communities, underlying substance use is colonization and colonial policies and practices like residential schools, the 60 Scoop, current child welfare practice, but it's also been systemically ingrained into institutional settings. And so as Nancy mentioned, as she highlighted the different practice approaches, brief interventions should be women-centered, they should be strengths-based, and they should be trauma-informed. And these principles are inherent to the wellness model. And so in understanding that, brief interventions really do need to be culturally grounded and relevant to the peoples and communities that providers are working with, and they really need to take a whole person approach that focuses beyond the individual to also acknowledge the land and the spirit. Brief intervention and support also needs to be adapted. So it should be available in the local language, it should integrate local data and local imagery, and all of that should be guided by the community. And so this might mean that brief intervention with Indigenous women and girls may look different. The community may ask that instead of a one-on-one conversation, that they integrate traditional exercises like land-based programming or blanket exercises. They might also ask for group brief interventions rather than a one-on-one conversation. And so we have highlighted two resources here, and one is from the First Nations Health Authority, and this is their harm reduction principles and practice that was developed as part of their opioid response. And the other is this booklet titled Wellness, which is one booklet in a series of 5 that we've created in developing Indigenous approaches to FASD prevention. And one thing that I want to mention as you go through the two documents is you'll notice that for Indigenous women and girls, we did not highlight examples or ideas for brief intervention with girls and women. And that's really because it should be fostered and created by the peoples and communities that you're working with.
Thanks, Lindsay. So we'll just come, to close to wrapping up here by talking a little bit about the interagency and system level work in a couple of slides. And, it just reminds me how important that all these principles for practice are relevant at the system level as well, and that we need to be thinking about how our systems support the integration of these principles in and support brief intervention modalities overall. And, in the course of the project, as we mentioned earlier, we met with people working in child welfare in many provinces and territories across the country and the Prairie Child Welfare Consortium to talk a little bit about this tension around, women fearing losing custody for having substance use problems and how we can improve the knowledge about that particular practice so that women can be clear that it's not substance use in and of itself that is a reason for losing custody. and that providers are very clear about what constitutes the duty to report. And in many jurisdictions, you are not required to report substance use in and of itself, but only if it is impacting parenting and child safety. And so I think we've got a lot of work to do in terms of the inter-system level between child protection and health and substance use fields. And just want to mention that, from arising from the meeting in this project, there was some really promising steps to improve this concept forward, excuse me, including some sessions that may well happen at the Prairie Child Welfare Consortium's fall conference in Calgary in October. And we're really hoping that some good dialogue about these tensions may be able to happen there. And nationally, we also found we had a lot of work to do to improve approaches to how we act, record, analyze, and share data on perinatal substance use. And here too, we see there was really lots of interest in thinking about how we can more closely align the principles and practices we've been talking about here with clinical professional guidelines and training, so that the way women are asked about their use in the perinatal period is really makes it safe for them to tell and for us to have better knowledge about levels and populations where we need to really put more energy. So that being said, I just want to quickly summarize and say that, we were absolutely pleased to see the level of interest in this work. And we really see the potential for many other professionals beyond nurses and physicians whom we've in the past thought the responsibility for screening, brief intervention, and referral largely fell to. But we see the potential for a lot of other professionals, as we've talked about this morning, to offer brief conversations on substance use that are educated and empowering. And we really hope that the two documents that we've created, the Doorways to Conversations and the 50 Ideas for Dialogue, Skill Building, and Empowerment documents, which pull out these 50 ideas from the larger Doorways document, that will be super useful to you. And, this interest and commitment to good practice is really heartening, and we hope that you will continue to see the importance of having these reflective conversations on substance use with all women, and really, think through, as we did in this blog, the pictures of a blog we do on FASD prevention, where we suggest that, we could reorder the screening, brief intervention, and referral model to put brief intervention first, and brief intervention in a way that's very much oriented around being educated about some of the risks of substance use and the connection amongst substance use in many areas of women's health, and support women in really thinking through what makes sense for them. As Lindsay mentioned, we've had the opportunity to work with a lot of the 8 professions in follow-up webinars and conference presentations. We're really looking forward to continuing that with the Canadian Association of Midwives and many others that we've got upcoming commitments with. but just want to signal to all of you who attend this morning that we are very much interested, even though this project is drawing to a close, that we are very much interested in collaborating with both governments and professional organizations, community organizations, and others as you continue to do work in this area. We'd love to walk with you on that. So we have a bit of time to talk about, to answer any questions that people have. I'm not seeing questions there. Are you, have you had a chance to look there, Lindsay?
No, I haven't seen any questions yet, so please, we encourage them.
We also keep a dialogue going on Facebook, our Facebook page, and through our Twitter account, as well as on our website. You know, please do stay in touch with us in these ways as well. And hopefully, you know, we have not completely flattened your enthusiasm with no questions, but just caused you to think and hopefully to have a look at these documents. So thank you one and all for participating this morning, and stay in touch.